Are you the host, Rocky?
I don't think, I think Shannon is. I don't think we have a host, I thought,
No,
because
you should be
anybody
able to
can,
share.
right, anybody can share, right? So
Great.
Correct.
let me see if this works. So can you guys see my PowerPoint? Yes, no?
Yes.
Yes.
Okay, great. Oh, and a little screen popped up. Now I see that you can see it. Okay, great. So let's just, we'll wait a couple minutes. I have 5:58 on my phone. And at least for the students, is Sydney on already? Because we don't have to go in exact order, but the order that I have, just for the students already on, you can see is this order. There's no particular, like rhyme or reason. It's just kind of the way I just put it together. But I have Sydney first, then Nate. Nate did send me, is Nate on? I told him to text in the text box. He told me he had a late staff out. I don't know what rotation he's on, but he said he might be late. He sent me a message on 5:10. I did get that message. So we might have to skip him.
Wait. Oh, okay. Sorry. I saw
Sorry, go
Nathan.
ahead.
No, I saw Nathan. I was like, who's Nate?
Number two.
Yep, got it.
So for, I was gonna say I don't want to like take up too much time, but I guess we got about a minute and a half and we'll probably wait till about 6:01. I got 5:59 now. But for all the students, I guess I'll just do an intro now and to save some time. And was Sydney on? Did we confirm
Yeah,
that?
she's
Sydney's on?
on.
Okay. So for all the students that are on it, for those of you who don't know, so I'm just going to go through this really quickly and I'll kind of my intro. But for those of you that know, there's better lighting now. Now you can see me. Okay. So for those of you that don't know, so the MRS, right? So Michigan Radiology Society, you can see the emblem there and everything. We are the state chapter for ACR, and ACR is the biggest national organization for radiologists. So radiology is kind of strange in the sense that for all the 27 specialties, radiology has the most organizations or clubs, whatever you want to call them. We have over 50. Last I checked last year, we had 54. So most, say FPIM, ER, whatever, most of them have like 4 or 5. Again, we have over 50. So with that being said, ACR is the largest, and we are the state branch of the ACR. So what is specifically this section, like the Medical Student Committee? So this was made 4 years ago, hence, right, fourth annual Medical Student Symposium. But 4 years ago, we had the great idea Dr. Danny Ma did at the time, who was the president, to start this committee. And the committee is two jobs that we're trying to do. Number one is get students interested in the state of Michigan, get students interested in radiology, right? And then secondarily, those students who are interested, try to help you because not all the schools have, adequate I guess I don't want to say funding, but adequate staffing, I guess would be better to say, for research and things like that. So we thought that by putting this together, that we would give you, right, an opportunity potentially to, present something at the state level. Being that we are, right, MRS or the Michigan Radiological State Society, that you actually, are presenting today at a state meeting. So you can put that also in your ERAS. So we're trying to buff up your application is kind of the main other thought we're trying to do, again, to make you stronger for hopefully getting a radiology residency. So that's the whole thought from today. And then just for everybody that's on, and for those students that are on, that did not get selected, that we had over 30 this year. Actually, I think it's 2 years in a row. We had over 30, over 35 presentations that were submitted, case reports. So it's really hard to pick because, 33 of the 35 are really, really good. So it's very difficult. But we had 3 independent people, rate everything. Myself and Dr. Klein, who was the other person, if you were logged on 2 minutes ago, talking, who is my co-chair for this medical student committee. We both reviewed them independently, and I had a third person independently also review them, all radiologists, of course. So, Dr. Klein, did you want to say anything before we begin? And we'll move to the
Yeah, I
second.
just want to really emphasize that they were very, very good cases. It was really hard this year. Um, and but that being said, if you did not get selected, please think about submitting your case to something it's called AAR now, but it was AUR, and that's the Medical Education Society of Radiology. And they do have medical students cases of the week. for case of the month. And then that would be published on their website. So think about submitting your cases to that, and I can, if you just reach out to me and I can direct you to the person you would submit it to.
Okay. Does anybody have any questions for Dr. Klein before I forgot to say something, but I didn't mean to interrupt you. Did you want to say anything else, Dr. Klein?
Nope.
So on this page, because I didn't go to it before, I would have remembered if I did this, so excuse me. But so I have the 7 there of our, I said over 35, case presentations that we had. So notice the first 5 are in blue. Why there's a demarcation, this was done on purpose. So technically the first 5 are the winners in no order. So all 5 are winners, they're all the same. We selected those, we thought those were the best. 6 and 7, because they're in gold, are honorable mentions. So with that being said, and I don't know if Dr. Kasatakas made it. I don't know if you're on, if you wanted to say something. I sent a late email last night to the foundation. So MRS has if you see that, that's actually what this is here. If you see my pointer. So we have a foundation, and what they do is support education, and they gave us $500. So the top 5 winners, or 1 through 5, if you're one of those names, you're going to get, last year, we did the same. The foundation gave us money, and I think it was an Amazon card. I'm assuming it would be something like that, or Visa card. You'll get $100 gift card. So which I will send to those 5 people. So the other trick I said are honorable mentions. So you can also put, obviously, that when you do your ERS app that you won, or that you're honorable mention. In addition, for the top 5 people, I also did it on my own. I actually have a 3rd edition of a CT book that I'm also going to send you. So I will also ask you for your mailing address later, because it's a hard copy. So with that being said, that's all I really had to say. And I was going to ask, is Sydney ready?
Yep. Am I able to share my screen?
You should be able to take it.
Okay.
Yeah, you should be able to just take it from me.
All right.
That's the way it's set up, hopefully.
Yes.
Perfect. So we would just ask, while she's setting up, everybody to mute. And obviously, if you have any questions, you can type them in at the end. She can, everybody, as they finish their presentations. Hey, Dr. Bloom, how you doing? I just saw Dr. Bloom on there. Perfect timing. So I was going to say is that then you can put your questions in, and the person can address it at the end. So with that being said, let's go ahead and start. Sydney, the floor is yours.
All right, that sounds good. So hi, everybody. My name is Sydney Torres. I'm a medical student at the University of Michigan, and I'll be presenting an interesting MSK case to you today that I worked on with my faculty mentors, Dr. Bloom and Dr. Joshi, in the Department of Radiology at the University of Michigan. So first I'll start with a case presentation. So the patient is a 12-year-old female who presented to her PCP with persistent and worsening lower back pain 2 months after a fall. Her pain is worse while she is sitting down at the end of the day and when she is more active, causing her to have to stand while she's eating dinner and frequently adjust while sitting in her chair at school. She has no neurologic symptoms, including numbness, weakness, tingling, difficulty with voiding or bowel movements. Here's her additional history, and just to point out a couple of items, her family history is unknown as she was adopted from Serbia at 5 years old, and before adoption, her parents had mentioned that she was malnourished with dental issues and heavy tobacco exposure. On physical exam, her PCP palpated a firm mass in the gluteal cleft that is fixed and slightly tender to palpation with an otherwise unremarkable neurologic exam. And so her PCP ordered an X-ray of the spine, sacrum, and coccyx. As you can see, this is the X-ray that was obtained, and we can appreciate that there is a large calcified mass with 3 main conglomerates of tissue around the coccyx. 2 are anterior, 1 is on the right side, 1 is on the left, and 1 is posterior to the coccyx, but otherwise the sacrum and coccyx appear to be intact. And to investigate the mass further, a CT abdomen pelvis was performed. And so I'll show you a partial video of a sagittal CT. And so here are some still images from the axial, sagittal, and coronal planes. And again, we can appreciate the mass here. It appears macrolobulated and densely calcified, arising in and enveloping the coccyx. There's no evidence of fracture or trauma. There's no definite fat or soft tissue components. And when considering both radiography and the current CT, the current differential diagnosis of the calcified mass included possibly the sequelae of a sacrococcygeal teratoma, a bone tumor with exuberant production of osseous matrix, or tumoral calcinosis. And so here's a summary of the CT findings just discussed. And when considering which diagnoses may be more or less likely based on imaging alone, there was no obvious intraosseous component and no bony destruction, making the bone tumor with exuberant production of osseous matrix or osteosarcoma less likely. There is no soft tissue, fat, or fluid components, making teratoma less likely. And tumoral calcinosis appeared to be the most likely condition given the macrolobulated appearance and enveloping from the coccyx without any osseous erosion, though a clear-cut diagnosis couldn't definitively be made from imaging alone. So there is additional workup that was done given the rarity of tumoral calcinosis and the odd location of the mass being in the coccyx, as tumoral calcinosis doesn't typically present there. And so additional workup was obtained, including a multidisciplinary tumor board discussion. And so here is the additional workup that was obtained, which first started with additional labs. So pertinent labs included mildly elevated phosphate, a mildly elevated active vitamin D, and otherwise normal tumor markers in other labs. And an IR-guided biopsy was then performed, which confirmed the diagnosis of tumoral calcinosis with no evidence of malignancy. And to further gather more information and plan for potential future surgery, a PET scan was obtained, which showed an increased uptake in the sacrum and coccyx as well as the lungs. The lungs were thought to be due to an infectious etiology, and the uptake in the sacrum and coccyx was expected. And interestingly, the patient had mentioned that her pain actually was potentially onset about 1.5 years prior after she had another fall. And so all in all, with labs, pathology, and imaging, the diagnosis is most consistent with tumoral calcinosis. And so what exactly is tumoral calcinosis and what causes it? So tumoral calcinosis is a rare benign condition where calcium and phosphate deposit in the soft tissues, often in the periarticular region or around joints or capsules. And there are several different causes, including genetic or familial inheritance, as well as secondary causes and idiopathic. And to look at each of those a little bit further, the genetic or familial inheritance can be either hyperphosphatemic or high phosphate levels in the blood, or normal phosphate levels, normal phosphatemic, each of which have associated genetic mutations with them. And secondary causes include renal failure, hyperparathyroidism, or rheumatologic causes. And any of these different causes are thought that tumoral calcinosis may arise in areas where there is repetitive trauma to the area. And so all in all, given the patient's high phosphatemic or high phosphate levels, it was thought that she has the hyperphosphatemic form. And so how does tumoral calcinosis present? It typically presents most frequently in patients with African or Middle Eastern descent in the first or second decades of life. The patients often present with reduced range of motion at the site with or without pain. There can be one lesion or many lesions that progressively enlarge over time, and they can have corneal calcifications or dental abnormalities. There are various locations that are most common, including the hip, as you can see the image of a different case of tumoral calcinosis in the right hip, or the elbow, the shoulder, the foot, or the wrist, but it can basically occur anywhere, typically near a joint, though the spine and the coccyx are quite rare. Classic imaging findings include the lobulated, heterogeneous, well-demarcated calcification, again along the extensor surfaces or periarticular with no erosion or osseous destruction, as we had seen in our patient. And so how is tumoral calcinosis diagnosed and treated? Again, it relies on imaging, labs, and pathology, and sometimes genetics. So first, starting with imaging, we typically start with an X-ray, which then you typically get a CT or an MRI to further characterize any concern for malignancy and looking at any future need for surgery. And then the same labs that I had previously mentioned are typically obtained, especially if there's a genetic concern, and a biopsy is obtained if there's any uncertainty in the diagnosis. If there's a concern for a familial etiology, a genetics consultation is often pursued. And in terms of treatment for familial tumoral calcinosis, you typically begin with medical management first to lower the phosphate levels, starting with a low phosphate diet and phosphate binders if the phosphate level is very high. And sometimes surgical intervention is pursued to remove the mass, depending on if there are it's affecting the patient's quality of life, though recurrence is possible after removal. And so circling back to the case, the patient did undergo a genetics consultation for which she was found to have a germline proximal chromosome 15 duplication in the Prader-Willi and Angelman syndrome region, though she doesn't have any symptoms of either of these conditions, and it was not thought that this mutation was the cause of the tumoral calcinosis, and so whole genome sequencing was sent out and is currently pending to look for those known genetic mutations that cause the familial forms of tumoral calcinosis. And so first they started with medical management where her lab abnormalities were resolved. And then, unfortunately, due to worsening pain, leg weakness, and mass effect symptoms that she had, including nausea, vomiting, and weight loss, she did undergo surgical debulking. As you can see in the image here, there is some residual calcinosis at the base of the coccyx, as this is a tough and risky location to pursue surgery, and there's also a post-op fluid collection that ended up being drained. And so I just wanted to show some other examples of tumoral calcinosis in the literature, as it is quite rare. So this first image is bilateral tumoral calcinosis of the greater trochanters. The second image is an abnormal case of confirmed genetic tumoral calcinosis in a 51-year-old female with vascular linear branching calcifications in the subcutaneous tissues of the distal leg. And then here is a patient, a 54-year-old patient with a history of systemic sclerosis with removal of a lumbosacral tumoral calcinosis. Again, the hip tumoral calcinosis. And lastly, a 22-year-old man with large tumoral calcinosis of the anterior elbow. And so what are the take-home points? Radiologists should consider tumoral calcinosis in masses with lobulated heterogeneous calcifications despite being in an abnormal location. The diagnosis of hyperphosphatemic familial tumoral calcinosis is multimodal and includes clinical presentation, radiographic findings, lab work, pathology, and genetic findings. And tumoral calcinosis is a rare diagnosis with typical management being based on case reports and case series with incidence and prevalence being unknown. And here are my references, and thank you all for listening.
Great job. I don't know if anybody has any questions. I don't see anything in the chat. Last time I looked, I was going to say you can always unmute too and ask a question. So
I have a quick question. Does it ever dissolve when you treat the hyperphosphatemia? Can it regress?
I was reading that there are some cases of spontaneous regression of the tumors. Yeah, sometimes that does happen. And I know there's various treatments too. There's like a topical treatment that I can't remember what exactly it was that some patients had success with as well.
Nice presentation.
Thank you.
yeah, great job. So I don't know if Nate, if you were here when I did the intro, but for all the other students that are presenting, also I put the order into the chat. But you can just share your screen, so you'll be presenting from your computer. So next will be Nate Kaufman. He's from MSU, College of Human Medicine. So he'll be our next presenter. So Nate, go ahead and on your computer, open your presentation, pick share screen, and it should go. And then
okay, thanks. Can you hear me? Okay.
Yes.
I think you and I are still in a private chat, by the way. So you put the order in, I think, our private chat.
Oh, I didn't realize it was private. My bad. Then I had the
Yeah.
wrong box open. I'll
Sorry, I should have told you. I put us in a.
No worries. Thank you.
Okay, great. So this is an interesting PEDS case. I'm Nate Kaufman. I'm a third-year med student at Michigan State College of Human Medicine. Cornwall Health Grand Rapids, and my mentor for this project was Dr. Joe Junwick. So our patient is a 21-month-old female with no prior medical history. She presents to the ED with 9 days of persistent fevers and reported Tmax by the family of 40.5 Celsius. She has decreased energy, oral intake, urinary output, but normal bowel movements. She hasn't had any skin changes over her course. Parents do report prior respiratory illness 3 weeks ago prior to her presentation. Another interesting fact, her family lives on a farm and she's constantly like petting and taking care of the animals. So other than that, though, really no other relevant history, no prior medical surgical family, doesn't take any meds. She has no allergies and she is up to date on her vaccinations. For her vitals, she's actually pretty vitally stable. When she presented to the ED, or even her temp was just 36.4, so wasn't actually hot when she was seen here. Physical exam, constitutional, she's active, not in acute distress, looking fine. No discharge or mucosal erythema. She does have some cervical lymphadenopathy. Cardiovascular, regular rate and rhythm, does have some tachycardia. Pulmonary, normal effort and breath sounds. Abdominal, she does have normal breath sounds, but distension was noted in kind of the right lower quadrant, maybe diffusely, not quite sure. Skin was warm and dry, neurological, no weaknesses, normal reflexes. Parental labs, clean on the CMP, CBC, white blood cell count not elevated, hemoglobin down to 7.4, platelets elevated at 897. Notably, CRP was elevated at 176.9 and ESR elevated to above 130. Diagnostics at this point, echo was done, that was normal. Next thing indicated was an abdominal ultrasound because of the abdominal distension and persistent fever. This is the results of that ultrasound. So what we can see here is a well-defined, minimally lobulated 4 by 4 by 4 centimeter mass. And that's seen here. So this is in the right lower quadrant, again with ultrasound. The red is uniformly hypoechoic. Turning on Doppler, we can see that this is hypervascular and variable throughout. At this point, differential diagnosis, I think this list could be expanded, but what we came up with was leiomyoma, GIST, peripheral nerve sheath tumor, solitary fibrous tumor, fibroid, lymphoma, carcinosarcoma, or inflammatory myofibroblastic tumor. CT was done to characterize this tumor. Is read as a solitary right lower quadrant mesenteric mass. So you can see that here. This is the coronal CT. The mass is also seen here on sagittal CT. And what you can see as well is that we're getting a lot of distended bowel kind of throughout. But other than that, there's no like ascites or no other major findings seen on this read. The tumor itself is read as minimally heterogeneous, but it is hyper-enhancing compared to the liver. I think you can appreciate that looking at the tumor here and comparing that to the liver parenchyma. And again, there's no other abdominal findings here. Again, MR was done to further characterize. This is FST1 on the left here, showing iso-intense mass similar to the liver. On T2 haste, it is not enhancing, but it is peripherally enhancing. And then on post-gadolinium T1, we can see that it is enhancing here, which is a sign of like a fibrotic tissue. On MRA, we can see that there is arterial supply coming from the SMA here. So this is our tumor here in the arterial supply. So at this point, surgery team was consulted. They felt comfortable that resection of this mass was the right next step. And so that's what was done. PET-CT was done post-operative period. This is post-op day 15. CT is on the left here. FDG PET is in the middle, and the fused image is on the far right. And what we can see, looking at the fused image, is that we're not getting any real hypermetabolic activity in the area of the tumor. This area here is just like ileocecal region, very normal to see uptake here, normal uptake in the brain, and then normal uptake kind of throughout the urinary system with clearance of that FDG PET. So this is good. This showed that the tumor was fully resected. I did follow up with this patient. It was about 3 months post-op, and all the notes said the patient was doing very well. So the important thing, what exactly was this thing? What was going on? Post-op pathology report did reveal that it was indeed a inflammatory myofibroblastic tumor. So what exactly is inflammatory myofibroblastic tumor, also known as IMT? The epidemiology of it, there's only approximately 150 to 200 cases in the US annually, so pretty rare. The clinical presentation usually is just related to mass effect and then usually some sort of non-specific constitutional symptoms. So that mass effect just depends on what location it's in. 2 of the more common locations is actually the lung and the eye. And so you would get signs if it's in the lung. You have dysphagia, you have difficulty breathing, it's in the eye, difficulty eyesight. With our patient, she just didn't really have too many abdominal symptoms, but did have kind of that systemic sign of the fever. And ironically, it is the most common primary lung tumor in children, so kind of an interesting fact. What exactly is IMT? So the pathophysiology, it's an overgrowth of spindle fibroblastic cells and inflammatory cells. So this is actually a pathology slide of our patient sample. This shows the spindle fibers kind of all throughout, and then inflammatory cells also all throughout. So this is basically bang on for IMT diagnosis. Another interesting thing about IMT is that ALK gene mutation is seen in about 60% of all samples. And so we can see that here on immunohistochemistry that this lesion is very avid for ALK positivity. So ALK basically gets upregulated, and that causes this to grow out of control, essentially. Unfortunately, it's an unknown etiology in our patient and just in general as well, but has been associated with chronic infection, autoinflammatory disease, and trauma. Further teaching points, natural history. Again, the tumor will just kind of continue to grow and continue to have whatever mass effect issues that you were having before, as well as any of those systemic symptoms of inflammation, such as fever. Untreated IMT will just continue to grow and do that. Not really the biggest risk of metastasis. There is a very small risk, though, about 5%. And that's why we resect these and we take care of these. Local regional recurrence is more likely, though, and so that's why getting really good margins of surgery is critical. And so this is a full section of our patient sample showing a bowel here at the top and then the IMT tumor here at the bottom. So showing that we did get good margins and good resection. Another treatment plan can be chemotherapy if resection is not achievable or the margins weren't great, something like that. And interesting enough, you can use ALK inhibitors if it is ALK positive, and also COX inhibitors. A lot of these tumors do have COX upregulation as well. So as far as further teaching points on the imaging, just going over the general features, not just in this case, but just in general. Typically well-defined and round, and when it does infiltrate, it'll just kind of infiltrate locally. It's usually 7 to 8 centimeters in size at the time of resection, so usually imaging is done kind of right around that time as well. So typically it will be about that size. Ultrasound specifically, hypoechoic, solid mass, and hypervascular. This is the same image that we were looking at before, and so we can see that this is hypoechoic and is quite vascular. CT MR, central necrosis calcification is very common. And then again, the T2 hypointensity that we saw on the previous imaging, kind of indicative of fibrosarcoma. And then it can be just general hyper enhancing on postgadolinium T1. And that's what we can kind of see here, is that it is slightly enhancing compared to liver parenchyma. And then finally on PET, we didn't see it with our patient because luckily we resected everything and got it all out. But you would see increased glucose uptake with this as well. The biggest takeaway from this slide is that all these features are very similar to how you describe a malignant mass in a patient like this. And so that's why it's so critical that we get this IMT diagnosis right, is because from a radiological standpoint, we can't tell the difference. So in conclusion, that's why IMTs are known as the great mimickers of neoplasm, because from, again, radiological standpoint, we cannot tell the difference. A lot of similarities, particularly in abdominal masses in children, which, again, this isn't just an abdominal mass in children diagnosis, but it is a very common, of the IMTs, it is a very common presentation. And so IMTs are underreported on radiological differentials because it is rare and because we are thinking more of a carcinomatosis, something like that. So IMTs are definitely underreported. Clinical correlation with inflammatory markers, that might be a way to kind of get IMT higher up the list. But IMTs, again, can only be differentiated by pathology. So we need to think about it as a potential diagnosis. That way we can get that pathology and get the right diagnosis. Because the treatment options can be very different depending on what type of mass it is, as you can imagine. So it's very critical for us as radiologists to be aware of this mimicker and other mimickers so we can guide proper disease management for our physicians and our patients. Here are my references, and thank you all very much for your attention.
That was excellent, Nate. Thank you so much.
Thank you.
Very interesting. Any questions for Nate?
I was just going to make a quick comment, which was, and Nate hit it right on the head, how it's, it can metastasize, but that's unusual, but it's a more benign lesion. Its old name used to be inflammatory pseudotumor. So for that same reason, so excellent.
Thanks, Dave. All right, so our next speaker is Tanaz Naruzi.
Hi,
Did I
yes.
pronounce that correct?
Yes, you did.
Great.
I'll go ahead and share my screen. Okay, can everybody see this?
Yes.
Great. Okay. So hi, everybody. My name is Tanaz Narozi. I am now a third year at OUWB, and I will be presenting an interesting body case that I worked with. And my mentor for this was Dr. Al-Khatib. So our patient here is a 68-year-old female presenting to the emergency department with a 2 to 3 day history of worsening, intermittent, sharp, stabbing, and non-radiating abdominal pain. She reported seeing some blood in her dialysis fluid that day. Some relevant aspects of her past medical history: she has a long-term chronic history of end-stage renal disease secondary to autosomal dominant polycystic kidney disease. She's been on peritoneal dialysis for over 20 years. She's had 4 episodes of peritonitis in the past, and some relevant medications to this case is her prescription of a continuous ambulatory peritoneal dialysis, which she's been on for a very long time. She has never smoked, she's never used smokeless tobacco products, and denies alcohol consumption and recreational drug use. These were her vitals coming in that day into the emergency department. So her vitals were generally in normal range. Her blood pressure was probably a little elevated. She is obese. Her physical exam findings: she was not in acute distress on exam. Because of her relevant cardiovascular history, they did an EKG on her, and she had normal rate, regular rhythm. She had normal pulses and heart sounds. Her abdomen was soft and flat. Bowel sounds were normal. There was generalized distension with abdominal tenderness, and there is a dialysis catheter in the left lower quadrant. Some pertinent labs that they had ran that day was some of the, I guess, abnormalities in her labs were sodium, potassium, and chloride were on the lower ends, and her BUN and creatinine levels were elevated. So her hospital course, she came in day 1. They gave her IV antibiotics and a proton pump inhibitor. Initially, I think they believed that it was an infection, and they also gave the proton pump inhibitor to address the abdominal pain. They ordered a pelvic X-ray and a CT of the abdomen and pelvis. And then on day 4, she was discharged in good condition with her abdominal pain improved. So this is the first image. This is a radiograph of the pelvis, and this picture demonstrates the fine linear calcifications that are located centrally and also on the right side. Here you can see this is her catheter right here, this little like thin line on the left lower quadrant, but you can see the fine linear calcifications along the bowel walls, and you can see it here on the right side as well. Here's an axial CT without contrast. This demonstrates more of the visceral peritoneal thickening that we see, as well as another demonstration of the fine linear diffuse calcifications along the bowel walls, and again, more of that thickening of the visceral peritoneum. And this picture doesn't show it great. There's another picture that will show it better, but there's a little bit of clumping that might be seen. And then right here, you can notice there is some ascites. Here's another picture, just a different perspective. Another axial CT, again, with the fine, diffuse linear calcifications, the peritoneal thickening, the visceral peritoneal thickening, as well as the ascites that's right beneath the abdominal wall. And this picture does show a better image of this clumping that looks like it's more localized to the right side. Here is a coronal CT that demonstrates, again, more of the diffuse linear calcifications along the bowel walls, and then the thickening of the visceral peritoneum. And then here is more of that ascites. Okay, so I'm going to break this down. So our differential at the top, we have encapsulated peritoneal sclerosis. It's short for EP or EPS is short for encapsulated peritoneal sclerosis. Some known causes of this is a long-term history on peritoneal dialysis and then recurrent episodes of bacterial peritonitis. Our patient, she has been on peritoneal dialysis for over 20 years. She's had 4 prior episodes of peritonitis that were positive for strep and complicated by staph. And then some characteristic case report findings that were continuously kind of mentioned were the CT usually demonstrates the fine diffuse calcifications along the small bowel walls, as well as the diffuse peritoneal thickening. This has been described as more of a cocoon-like structure that looks like it looks like it's encasing the peritoneum. And then the second one is peritoneal carcinomatosis. So this generally arises in patients with a history of ovarian and GI malignancies. Our patient has no prior history of either. And imaging would reveal more of a nodular thickening with more omental nodularity, which is absent in our patient. And then at the bottom, we have peritoneal amyloidosis. This presents generally with non-specific abdominal pain, which EPS does present the same way with symptoms of like nausea, vomiting, generalized abdominal pain. So clinically presents similarly, but you would have more organ-specific findings, maybe abnormal labs, splenomegaly, and our patient had isolated findings that were localized to the peritoneum with no other organ involvement, and there were no other abnormal lab findings that could indicate some other organ involvement. So a little bit of background on encapsulated peritoneal sclerosis. It is a rare and fatal condition that characteristically presents, again, with the encapsulation of the bowel in fibrocollagenous peritoneal membrane. Some common, well-documented predisposing factors are patients that have been on long-term peritoneal dialysis, bacterial peritonitis, and tuberculosis is also a well-known cause. Clinical presentation is generally nonspecific, like we had mentioned, and some specific radiographical imaging modalities that are usually used are going to be CT at the top, and ultrasound also has specific imaging findings that you could correlate to the specific diagnosis. Diagnosis is generally made based on patient history, clinical presentation, and imaging findings. Diagnosis can be confirmed with laparotomy or laparoscopy, but this isn't done. It's rarely done because of its invasive nature. Some current treatment options, it's more conservative management, but medications usually are immunosuppressive agents, corticosteroids, tamoxifen has been used, and another important aspect is taking patients off of peritoneal dialysis for some amount of time and starting them on hemodialysis. And this is more of the goal to rest the peritoneum and in this situation, and supportive care due to the risk of malnutrition in these patients. Surgical interventions can be offered because these patients can end up developing adhesions over time, which can lead to acute obstruction. But it's rarely done. Thank you. And these are my references.
Excellent presentation.
Thank you.
Very interesting cases. Does anybody have any questions for Tanaz? Okay, if not, again, congratulations on being one of the top 5 winners. Our next presenter is Vani Pathik from Michigan State.
Okay, hi. Can everyone hear me okay?
Yes, excellent.
Okay, perfect. So hi everyone, my name's Avani. I'm a 3rd-year student at the Michigan State University College of Osteopathic Medicine, and I have an interesting interventional radiology case to share with you all. So to start, the patient today is a 13-month-old male with a past medical history of biliary atresia, and he has just received a liver transplant that was done 2 weeks prior within the same admission as this case. And he's presenting with increased biliary drainage, which is concerning for a bile leak. So in terms of the medical history, this patient has end-stage liver disease along with portal hypertension and a history of failure to thrive. In terms of past surgical history, He, of course, received the liver transplant with Roux-en-Y hepaticojejunostomy, as well as a drainage catheter placement by interventional radiology. And he also had a previous failed Kasai procedure. In terms of medication, this patient is mainly on immunosuppressives for the liver transplant, as well as infection prophylaxis medicines. So because this patient has been in the hospital for 2 weeks already, I wanted to go over some of the details of his stay so far. So after the liver transplant, an abdominal CT was done, which showed a perihepatic fluid collection, and that was why a drain was placed by interventional radiology. A few days later, however, the drain started producing increased bilious output, and then a repeat CT as well as a HIDA scan were done that showed a persistent fluid collection. And I have those images on the following slides. The next step was an exploratory laparotomy that was performed to manage the leak, and so sutures were placed to close tissue and the drain was replaced. So this is the CT scan that was done, and the arrow is pointing out an encapsulated perihepatic fluid collection. And this was the HIDA scan that was done. And with HIDA scan, the tracer that's used represents the presence of bile within the body. So the arrow here is pointing out that there's tracer activity in the surgical drain, indicating that there is a bile leak. So then coming back to the patient's current condition, I have their objective exam. So in terms of vitals, they are pretty much within normal limits, aside from some tachycardia. And then on physical exam, in general, they're in no acute distress. There's only mild icterus in the eyes. The respiratory and cardiovascular exams are unremarkable. However, when it comes to the gastrointestinal exam, they are mildly tender on the right side of the abdomen, which also has distension, as well as the drain in the right lower quadrant has an output yielding about 100 cc's of dark bilious appearing fluid, which has been collecting over the past 24 hours. In terms of labs that were done, the main significant finding is the increase of bilirubin within the drain fluid. So the first step that was done in evaluating this fluid leak that the patient was presenting with was a liver ultrasound. So in this ultrasound image, the arrow is pointing out an irregular small fluid collection that was previously not present. In order to address this fluid collection, a percutaneous transhepatic cholangiogram was performed and a biliary drain was placed. So this image here is showing the successful placement of a 6 French internal and external biliary drain. So after this intervention was done, the drainage from the previous drain has remained decreased, indicating a successful intervention, and the patient is scheduled for a repeat percutaneous transhepatic biliary drain cholangiogram for 8 weeks later. This patient also had a PICC line placed so that they can receive prophylactic antibiotics, which they need to stay on as long as their drains are in place. And the patient will at home continue their medications for their liver transplant, including the prednisone and tacrolimus, as well as the antibiotic and antiviral prophylaxis medications. So based on the case that I presented, I have a couple of interesting points I wanted to go over in the next few slides. So the first thing is, what are the indications for pediatric liver transplant? So a transplant is indicated for patients with end-stage liver disease. Pediatric patients constitute 7.8% of all liver transplants, and the goal is to increase their life expectancy or their quality of life. Liver failure could be due to a variety of reasons. In this patient's case, it was their biliary atresia, and it can also be due to intractable portal hypertension, as well as recurrent life-threatening inflammatory conditions, such as cholangitis, spontaneous bacterial peritonitis, and failure to thrive. And one interesting thing to note about the pediatric liver transplant is that the preferred biliary reconstruction is actually the Roux-en-Y hepaticojejunostomy, which is different from what's done in adults, which is actually a duct-to-duct reconstruction. So liver transplants can come with a variety of complications. The main two categories are either vascular or biliary complications. One statistic to note is that the 5-year survival rate is 76.4% for a first pediatric transplant versus 64.5% for a repeat transplant. When it comes to vascular complications, the most common are hepatic artery thrombosis or stenosis. When it comes to biliary complications, the complications include strictures, leaks, obstructions, and more. The risk factors for biliary complications are prolonged ischemia time, hepatic artery thrombosis or stenosis, cytomegalovirus infection, or chronic rejection. As we saw in the case, ultrasound was an important first step in identifying the fluid collection, and indeed is very useful at many different stages of the pediatric liver transplant. So it's useful in donor, recipient, and complication evaluation. And it's particularly good because it's safe for pediatric patients due to the absence of radiation. It's low cost and highly accessible. However, one thing to note is that ultrasound quality is operator dependent. And then finally, about percutaneous transhepatic cholangiography in general. For pediatric patients, this is one of the go-to modalities for evaluation and intervention for post-liver transplant biliary complications. In adult patients, an ERCP would be done. However, this is not possible in pediatric patients due to the Roux-en-Y biliary enteric anastomosis. Moreover, PTC is minimally invasive. One thing to note is that the post-PTC biliary drainage management is a long-term commitment, so many drain changes are possibly required, as well as repeat cholangioplasty may be necessary, as well as patients have to be on antibiotics as long as their drains are in place to prevent infection. And then finally, a 2022 single center study found that PTC and biliary duct catheterization was successful in all their cases of liver transplants, and they showed that the procedure was safe and effective. So in conclusion, percutaneous transhepatic cholangiography and biliary drain placement is a useful intervention for a bile-leak complication after a pediatric liver transplant. And that is the end of my presentation. Here are my references, and thank you all for listening.
That was excellent. Very good.
Thank you.
David, did you have a question? Okay.
Just clapping.
Okay.
I will say it's impressive. It's not easy to place a drain percutaneously into the Roux-en-Y, which is what they did for the internal external. So that's kudos to those who did it, including Avani.
Yes, and the main attending was Dr. Keikos at the Detroit Medical Center. So shout out to him. Thank you.
If we don't have any more questions, we have our final presentation from Hamza Kakarli from the University of Michigan.
Good evening. Is my screen sharing okay?
Perfect.
Awesome. Alrighty, we'll get started.
Hi everyone, I'm Anna, and I'll be presenting an interesting GI case with my classmate Hamza. We're both second-year medical students at the University of Michigan. So our case begins with a 69-year-old female who presents to the ED with several months of persistent fatigue, early satiety, vague abdominal discomfort, and possible weight loss. Her past medical history is significant for GERD, an abdominal hernia, a duodenal adenoma, for which she had a Whipple in 2017, and choledocholithiasis, and she's currently on ursodiol at this time. In the ED, on physical exam, she's tachycardic. Her skin is jaundiced, though she reports she has mild jaundice at baseline. And we notice a right biliary drain on abdominal inspection.
Her labs are significant for a total Billy of 2.3, down from 3.3, an ELK phos of 268, down from 406, and a mild leukocytosis at 10.2. So what's our differential diagnosis and what imaging are we wanting to get? Her presentation is concerning for a GI malignancy, given her fatigue, possible weight loss, and her adenoma history. Another possibility could be a hepatobiliary obstruction, given her abdominal discomfort, her elevated LFTs, and her gallstone history. Finally, a duodenal obstruction or post-Whipple changes could be the cause of her vague abdominal discomfort and early satiety. Given our clinical suspicions, we obtained a CT abdomen and pelvis, as well as an MR-MRCP. On imaging, our CT allows us to visualize the liver and the intrahepatic biliary dilatation, left more so than the right. There's also a small amount of hyperattenuation surrounding that dilatation, which may be secondary to an infection or inflammation. It's also visualized on a coronal view on the right side of that screen, which confirms the dilatation that's surrounding hyperattenuation, as well as the right-sided biliary train. On axial view of our MR-MRCP, we again visualize that right and left hepatic ducts, and we can follow that hyperintensity to the obstruction distally. Our imaging evaluation allows us to rule out GI malignancy, as well as our duodenal obstruction and post-Whipple changes. It allows us to conclude that our 69-year-old female's presentation, labs, and imaging is most consistent with choledocholithiasis and possible cholangitis.
So as we move on and we have our working diagnosis, there are some important anatomical barriers to consider as we plan our intervention. And name among those is the Whipple procedure the patient underwent in 2017. Taking into account the post-Whipple changes with the stomach ending in kind of a blind pouch and then being connected to a distal portion of the small intestine, as well as significant resection of the gallbladder, the duodenum, and then portions of the biliary system that were then reconnected to the small intestine. That kind of creates a difficult opportunity, but an opportunity nonetheless for interventions, kind of going through what we can offer this patient as she presents to us. So an ERCP, given this difficult anatomy, is no longer viable. The Whipple procedure kind of makes it almost virtually impossible to get an endoscope where it needs to be in order to intervene. Similarly, this patient had an attempted rendezvous procedure at an outside hospital before presenting to us, which is partially the reason we can see that she has a right-sided drain in place. Also, which has kind of influenced her labs to trend somewhat downwards over the past 10 days. While this patient does have a right-sided biliary drain in place, the long-standing maintenance that would be required with a biliary drain replacement every 6 weeks, as well as almost daily drain care and maintenance, kind of make this a non-viable option for long-term use, especially in a patient who's 69 years old and she's already overcome so much. This leaves us with biliary endoscopy and stone removal as the most viable option in terms of intervention on this patient's obstruction. And how do we visualize the stone? We have right-sided existing access through percutaneous transhepatic cholecystostomy tube. And so that can be used as an access site to fit in the spyglass visualization system, which doesn't require anything else, just using the tube that is present. And so we have a picture of the spyglass on the screen. And then we're able to use the existing access to enter into the biliary system and then visualize our obstruction in order to pass an intervention on it. And as you can see, kind of correlating to the imaging we had previously, there is a significant impaction or obstruction. And how do we intervene on this? So the technique that was used in this case was electrohydraulic lithotripsy that can be delivered with the spyglass device in place. This technique was used due to the failure of a snare attempt that was we tried to pass a snare distal to the obstruction in terms of the spyglass and then kind of pull it out. However, lithotripsy was the most viable option. And so moving on after lithotripsy, we can get a more complete visualization of the system that we're working in and how our lithotripsy has worked. And this is our final pullback from the right side all the way out of the biliary system through our PTC. Moving on to pre and post procedure imaging. On screen left, we have pre-procedure imaging, and we can see the obstruction as well as the dilatation. 10 months post-procedure, the patient had an MRCP repeated. We can see there is almost complete patency. There is some non-obstructive choledocholithiasis left in the right side. However, the left side, which was kind of the primary cause of the patient's issues, has been completely resolved, and the inflammation has trended in the positive direction. Outcomes after 3 months, significantly noted, the patient said it had been 5 years since she had been able to do some activities that she had now returned to after the drains had been removed 6 weeks after the initial procedure. She did note that, expectation setting is important. The tracks took a little longer to heal than she had expected, but she was overall happy with them. And from a laboratory perspective, there was continued monitoring of her labs over the next several months, and those liver numbers that we had noted earlier had all trended to within normal range. Things to note in terms of this case and kind of the applicability for patients with complex anatomy, endoscopic approaches might not be viable options. And so always considering the interventional aspect and especially using biliary access to intervene. Importantly, in quality of life, while drains are very important and very useful for patients, they do have some kind of effects that, patients don't like to live with drains. And there's a lot of drain care and drain maintenance, as well as repeated visits to the hospital roughly every 6 weeks. In terms of broader application, there are many patients who are not surgical candidates for whichever comorbidity it may be. This case was pulled from a handful of cases at our institution, and other things that we can consider using interventional radiology for could be cholecystitis cases where general surgery is not comfortable operating on the patient, and interventional radiology has ablative techniques that can be offered to patients. At this time, I'll open it up to questions.
Again, another fascinating case with some fascinating tools. So did you go through the tube that was put on the outside?
So there was right-sided biliary access. And so there was a peel-away sheath kind of at the beginning of the procedure. There was a peel-away sheath put in place. And then I believe it was the bigger tube was 13 French, and then the spyglass was 10.5.
Oh, wow.
Interestingly, you mentioned that previously, I think it was at an outside hospital, they attempted a rendezvous technique.
Yes.
Which is interesting because that means the endoscope would have to go through the gastrojejunostomy and retrograde all the way up into the limb in order to get to the wire coming through. I can't imagine that was an easy thing to do. Were they successful at even getting close?
No, kind of doing some digging, I was able to find the attending who did the procedure at the outside hospital. And he had mentioned why it was so difficult, and he had commented on the Whipple anatomy.
Yep.
Leading to that outcome.
Yeah, for those who don't know, you endoscope to the papilla normally, and then through PTC, you bring a wire through, and then you sort of meet, you rendezvous, and then you can work either way. But through a Rulu, boy, oh boy.
Yeah. Well, I want to thank all of our presenters, and Shannon will be reaching out to you for your prize and the cases. And thank you, Sarah and Bilal, for your cases as well. We will be posting up the cases on the website, and also just keep in mind what I told you about the Academic Association for Radiology, formerly AUR, but if you want to submit a case, I can help you for the case of the week or the case of the day. That was an excellent job. All right, 6:58. Any other final comments? Good.
Except to say that I'm very impressed, and radiology is in good hands in the state of Michigan.
I totally agree. All right, take care.